My name is Gabriela Berlocho. I'm a hematologist at the University Clinic and the University of Bern. I would like to explain you this on a scheme. You can see a very simplified model for the hematopoiesis on this scheme with the hematopoietic stem cell, which divides into daughter cells, ultimately producing all types of blood cells. With each cell division, a small part of the chromosome end by the telomere is lost. But this loss can be compensated by telomerase, the enzyme which can add new telomere repeats. Physiologically, telomerase is only expressed in early hematopoietic stem and progenitor cells and in certain types of lymphocytes. In contrast, in cancer cells and in the situation of clonal hematopoiesis, as seen in myeloproliferative neoplasias as essential thrombocythemia, telomerase is pathologically reactivated and confers an indefinite replicative potential to these cells. And that is the target for the telomerase inhibitor Imetelstat. There's a phase 2 clinical trial of Imetelstat in myelofibrosis. Has been opened just recently for patient enrollment. And this phase 2 clinical study will evaluate the activity of 2 dose levels of Imetelstat in patients with DIPS intermediate 2 or high-risk myelofibrosis who have relapsed after or are refractory to a JAK inhibitor. The study will be conducted at multiple sites across Europe, North America and Asia. A clinical study in MDS is also expected to open for enrollment by the end of 2015. As far as I'm aware, Imetelstat is the only telomerase inhibitor in clinical development. Imetelstat is an oligonucleotide, but it does not work by an antisense mechanism. It is a direct inhibitor of the enzyme by binding to the RNA template of the reverse transcriptase enzyme, which you can see schematically here. There have been studies before, but a really success has been with this fundamental study in essential thrombocythemia. It's a phase 2 study where we investigated whether patients with essential thrombocythemia who had not had a response to or had unacceptable side effects from prior therapies demonstrated a hematologic and molecular response. A total of 18 patients were treated with Imetelstat with 7.5 or 9.5 milligrams Imetelstat per kilogram of body weight intravenously once a week until the platelet counts of approximately 250 to 300,000 per cubic millimeter were reached. Imetelstat induced hematologic responses in all 18 patients and 16 had a complete hematologic response. 7 out of the 8 patients were positive for the JAK mutation, had a molecular response, and the mutant allele burden of patients with calreticulin and MPL mutations were also reduced. Such rapid and durable hematologic and molecular responses had not been seen so far with standard treatments. There are over 400 patients have received Imetelstat in phase 1 and 2 clinical trials. Across these studies, cytopenias have been the main dose-limiting toxicity, which appear to be manageable with dose modification and retreatment guidelines. The other most commonly reported adverse events in Imetelstat clinical studies conducted to date include fatigue and gastrointestinal symptoms. Patients in these studies also experienced elevated liver enzymes, which resolved to normal or baseline in the majority of patients who were followed after Imetelstat treatment was withdrawn.